Welcome to this week's ABG of the Week, case number 1. This is a very interesting patient who is a 75-year-old diabetic, hypertensive female presenting to the hospital with fever and altered sensorium. She had recurrent episodes of loose motion and vomiting for the past 2 days, and a blood gas was done. And this is her laboratory value. You have the blood gas, the electrolytes, and the lactate. I want you to interpret this ABG. But to do so, you need to pause the video at this stage, get hold of a paper and a pen and a calculator, and draw your own conclusions about what the interpretation of this ABG is. Remember, answer 4 questions. What is the oxygenation status? What is the ventilated status? What is the acid base status? And finally, give a clinical summary of the abnormalities that you found, correlating it with the history and data so as to help you in the diagnosis or treatment of this patient. So once you have got your answer committed on paper, then resume this video and see what the answer would be. So resuming this video now, the oxygenation status. The oxygenation status, you need to look at the PaO2 and the FiO2. And in this case, the patient is on room air. The PaO2 is within the normal limits, so the oxygenation is normal. The second question is, what is the ventilator status? In order to answer what the ventilator status is, you need to look at the PaCO2. Is it below normal or above normal? In this case, it is below normal, and therefore the person is hyperventilating. Now come to the acid-base status. In order to determine the primary acid-base disorder, always start with looking at the pH. Is the pH low, in which case there is an acidemia, or is it high, in which it would be alkalemia? And then you need to look at what explains it. Does the PaCO2 explain it, in which case it's a respiratory disorder, or does the bicarbonate explain it, in which case it is a metabolic disorder? In this case, the pH is low, so there is an acidemia, and the low bicarbonate explains it. So the primary disorder is a metabolic acidosis. Whenever you pick up the primary disorders, the next step, the very next step, almost like a reflex, should be calculation of compensation. Why do you calculate compensation? Is to pick up hidden disorders which were not apparent on first viewing the report. So the compensation. Now remember, in metabolic acidosis, the primary disorder is a fall in bicarbonate. The compensation is a fall in PaCO2. For every one fall in the bicarbonate, the PaCO2 falls by 1 to 1.5. That's the range, 1 to 1.5. In this case, for example, the bicarbonate has fallen from 24 to 10, that is a fall by 14. So the PaCO2 would fall by 14 to 21, and the expected PaCO2 then becomes 19 to 26. You get a range. Not all formulas give you a range, they give you a value, and therefore it becomes difficult to pick up hidden disorders. The expected PaCO2 is 19 to 26. In this patient, the PaCO2 is 27, almost close to the upper limit of expected, and therefore we can say that there is appropriate respiratory compensation, and which means that there is no primary respiratory hidden disorder. Now, having calculated compensation and looked for hidden disorders, we must work up the metabolic acidosis. And for every case of metabolic acidosis, the first thing you should do is pick up what is the anion gap. In this case, anion gap is sodium minus chloride plus bicarbonate, which is 14. Now remember, you often hear of anion gap And what you actually mean is actual anion gap. But there are other forms of anion gap like expected anion gap, delta anion gap, which you should also know. Because without knowing the expected anion gap, the actual anion gap interpretation is impossible. The It is an error to always assume that the expected anion gap will be 12 because in reality, especially in critically ill patient, the expected anion gap can range from 6 to 22, and therefore you cannot interpret the actual anion gap without knowing the expected anion gap. So in this case, we know that the actual anion gap is 14. The expected anion gap, the way to calculate is take 12, apply a pH correction and apply an albumin correction. In this case, since albumin is not given, we assume it to be normal and therefore there is no correction applied. But for pH, in this case, there being acidemia, the correction is -2. So the expected anion gap is 12 minus 2, which is 10. What is the interpretation? The actual anion gap of 14 is more than the expected anion gap of 10. Therefore, this patient has a high anion gap metabolic acidosis. It doesn't end there. What about hidden disorders? In every case of high anion gap metabolic acidosis, you should look for hidden disorders. Mainly, is there associated normal anion gap metabolic acidosis or metabolic alkalosis? To do this, you should first calculate delta anion gap, which is the difference between the actual anion gap and the expected anion gap. In this case, it is 4. Now, you take this delta anion gap and add it to the actual bicarbonate to get what is called the corrected bicarbonate. The corrected bicarbonate is the actual bicarbonate plus the delta anion gap. In this case, actual bicarbonate being 10, delta anion gap 4. So the corrected bicarbonate is 14. If the corrected bicarbonate is 24 plus minus 2, there is no hidden disorder. But if it is less than 24, in this case actually less than 22, the implication is that there is a hidden normal anion gap metabolic acidosis. So what we realize is by using delta anion gap and corrected bicarbonate, we picked up a hidden disorder, namely normal anion gap metabolic acidosis. There's another way to approach this, which is popular in some areas and some hospitals in some countries, which is to calculate the gap-gap ratio. The gap-gap ratio being the ratio of delta anion gap upon delta bicarbonate. But in my 40 years of teaching blood gases to various categories of doctors in India and outside, I have found the gap-gap ratio to be more confusing than beneficial. And the corrected bicarbonate gives the same conclusions. Now, the final and most important step is a clinical sum up of the whole thing. In this case, the oxygenation was normal, patient was hyperventilating, and there is a high anion gap metabolic acidosis with the normal anion gap metabolic acidosis. The important thing is to look at the clinical history and the data to find out what is the cause of HAGMA and NAGMA, because in medicine, it is treatment of the cause which is more important than just correcting it. So, what could be the cause of high anion gap metabolic acidosis? In this case, the data is not conclusive. We do not have enough data. If we knew the blood sugar and if it were high, we could think about diabetic ketoacidosis. And if we had the urea creatinine, we could have probably suspected renal failure as a cause. Lactic acidosis also causes high anion gap metabolic acidosis, but in this case, the lactates are given and are in the normal range. So there is no lactic acidosis. Other causes which are not mentioned here and the history doesn't support it is poisoning, especially alcohol intoxication and salicylate poisoning, but there is nothing in the history to suggest that. What is the cause of normal anion gap metabolic acidosis? Well, in this case, it appears to be multifactorial. Loose stools definitely cause a normal anion gap metabolic acidosis, and there's history of recurrent episodes of loose motions. So that is one. And the second is in this person with loose stools and vomiting, who is almost certainly dehydrated, he would have received large volume of normal saline, and this normal saline in large volume can cause hyperchloremic metabolic acidosis, which is another term for normal anion gap metabolic acidosis. Just for teaching purposes, in every patient with diabetes who has a normal anion gap metabolic acidosis, always consider the possibility of renal tubular acidosis type 4. But in this case, since the potassium is low and in RTA type 4 the serum potassium is high, we can exclude the possibility of RTA type 4 in this case. I hope you enjoyed this blood gas. I hope you appreciated the importance of calculating the expected anion gap, the delta anion gap, and corrected bicarbonate to pick up hidden disorder in this patient with HAGMA, which was the presence of NAGMA, and also the importance of calculating compensation the moment you pick up primary disorders. I hope you liked this ABG of the week. Please leave your comments and suggestions below. If you liked it, we would be happy to know that. If you didn't like it, please tell us what we could do to improve our presentations. Was I too slow? What, did I speak too fast? What, did I make it too simple? Was it very confusing with too many technical terms? Whatever your suggestions are, whatever your comments are, please leave them below. And don't forget to hit on subscribe button below and also click on the bell icon so that whenever a new video is uploaded, you will be informed immediately. If you have in your practice an interesting ABG, please send it to us along with the short history so that we can include it in the future ABG of the week episodes and acknowledge your contribution as the source of the data. Stay safe. Enjoy your learning.